provides the educational support for the program. It comes from Gilead Sciences, and all of the content is completely independent from any influence from Gilead Sciences. Just a heads up to everybody. Also, so you know, you will be sent this entire slide deck after the meeting tomorrow in a follow-up. So if you want to read it more carefully, more closely, you'll have that option. The target audience for the ECHO HBV Bootcamp is really anybody and everybody involved in the care of patients with hepatitis B. We're trying to attack this from all angles and really just give you the most comprehensive education that we can. Here you have a joint accreditation statement. So this program is accredited by the Postgraduate Institute for Medicine. Again, you'll receive these slides. You can look at it in more detail if you'd like. Again, this is a message about CME credit. Each bootcamp is accredited for 1.0 AMA PRA Category 1 credits. We also have AAPA CME credits for this program. There is also nursing education available, so each module is worth 1.0 contact hours. Here is some language. Sorry, I just want to make sure that everyone's muted here. Perfect. Here you have a little message about MOC credit. So if you're interested in claiming MOC, there's some information about how to most effectively do that, as well as a disclosure of conflicts of interest for both faculty members, for both Dr. Bimidamari as well as Dr. Perumalswami, who's your sort of faculty mentor and leader for these next few modules. The PIM planners and managers have no disclosures to report. Lastly, we have a disclosure of unlabeled use, as well as a disclaimer. Now, before we move on to just a few sort of pre-test questions that we want to use to gauge how you all feel prior to the education, as I mentioned before, Project ECHO really is sort of a unique program, both in what they're trying to gauge and the way that we actually implement this education. So I'm going to play a short video, about 1.5 minutes, to just give you all a little bit more information about Project ECHO. So if you give me one moment here, I just have to stop sharing for 1 second and reshare. And now, here we go.
Project ECHO is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centres and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under ECHO, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project ECHO, changing the world fast. Join us at echo.unm.edu. Are you part of the ECHO?
All right, so that's just a little bit of information about Project ECHO as a program. As I mentioned before, one of the key facets of ECHO is the focus on case presentation and real-world practicality. So throughout the next 5 weeks, we're going to be asking some of you to volunteer, as many people as possible, ideally, to volunteer to present patient cases. However, we do want to protect patient privacy. A lot of times, these cases are based off of real people who you have seen or will see in clinic or in the hospital. So here on the screen, you'll see a HIPAA privacy statement. Again, you'll have this slide sent to you, so you can always refer back to it. And you may be wondering, what are some of these identifying factors that could reveal the identity of a patient? So here are some of the most common slip-ups that people might make when presenting a patient case. Please do not use a patient's first, middle, last name, or any initials that could be used to identify who they are, as well as location. You can use the state because it's general enough, but please do not mention the county, city, or town. Furthermore, please don't use dates such as birth dates. You can use the age as long as it's not above the age of 89, because that is such a small pool that it actually could be identifying information. So please don't use birth dates, rather use age. Also, Please do not identify a patient's employer, their work location, what their occupation is. And lastly, please do not identify a patient's family members, friends, coworkers, email addresses, really anything that could be traced back to a real person. As much as we want this to be real world based and educational, we also do want to protect the privacy of all patients. So that's part of our focus here. All right, before I officially pass things over to Dr. Perumalswami, who will be leading you through today's module, we have a few polling questions that we'd like to gauge. So you're going to see 3 questions appear one at a time on the Zoom platform itself, the first of which should be showing up now. The question is, and we're asking you to answer, how confident are you in identifying patients who are at high risk of hepatitis B? Do you currently feel not confident, slightly confident, moderately confident, or highly confident? So you can interact with that polling question on your screen directly, and I'll leave it up for another 10 seconds or so. All right, leave it up for 1 or 2 more seconds, give everyone a chance to answer. Great. The second question we have for you, which is also a confidence-based question, is how confident are you in overcoming patient barriers to screening? Do you feel not confident in overcoming those barriers, slightly confident, moderately, or highly confident? And again, that'll be up for another 5 to 10 seconds. Great, thank you all for responding. Just 2 more questions. For the next question, we're asking you how much you agree with this following statement. The statement is, I am able to identify patients who are at high risk of hepatitis B. So do you feel that you are never able to identify such patients, rarely able, sometimes, often, or always able to identify these patients? All right, 1 or 2 more seconds there. Great, and our final question for you before we get into the lecture itself is a knowledge-based question, which is asking, which of the following geographic areas has a high prevalence of chronic hepatitis B? Japan, North America, Africa, Australia, or all of the above? So that'll be there for about 15 to 20 seconds. All right, about 5 more seconds here. Give everyone a chance to interact with the question. Perfect. All right, well, thank you all for those responses. We'll be asking a few more polling questions at the very end of the presentation as well, so keep an eye out for those, as well as I'm gonna provide a few more sort of housekeeping items that we'll need to go over at the end. But for now, I'm very happy to formally introduce you to your faculty mentor for these next 5 modules. Again, this is Dr. Ponni Perumalswami. She's joining us from the Icahn School of Medicine at Mount Sinai. She's from the Division of Liver Diseases. And Ponni, we really appreciate you being here to guide us through these next few modules. So whenever you're ready, you can share your screen and take it away.
Great. I want to thank everybody for taking time out of their busy days to join us for the first of a 5-part, web-based series. And I'm going to go ahead and share my screen. Hopefully you can see that. Great. All right, so this 5-part series is really meant to take us through kind of epidemiology, screening, and then moving kind of more into serology. And we're actually going to spend 2 sessions, separate sessions, the next 2 after this one, on serology interpretation, because I think that ends up becoming a very big barrier to adoption of Hep B care and practices, and then move a little bit more into the details of how to monitor and manage patients with hepatitis B. This is really meant to be an interactive series. You have my personal direct ways of contacting me through my email as well as my phone number, so don't hesitate to reach out to discuss cases during the series and even after. This is really meant to build a knowledge network, and really I'm here to help be a resource to folks participating in the program. All right, with that, our educational objectives for today's webinar is going to be to identify regions where hepatitis B is prevalent and the importance of screening patients from these regions. So talk a little bit about epidemiology globally and hear what we see in the United States. And then really to discuss culture-specific patient barriers in your current patient populations. For this first webinar, we're actually have developed a video that we're going to use as our case-based discussion. For the subsequent modules, we're going to ask for folks on your side to really submit a case, and Kate and Rachel will send around some of the case forms that we're going to use. If you don't already have them, it's kind of a standardized format in which to submit the case so that we can use it as a way of discussing. And the reason for this is that a lot of how we learn in as healthcare providers is very much focused on a case-based discussion, and I think that really helps us remember the information. So let's start with screening and having the conversation. So we'll start a little bit about some of the epidemiology here. So we estimate globally that there are 2 billion people who have been infected with hepatitis B at some point in their lifetime, and that close to 260 million persons are chronically infected. Here in the United States, the latest estimates, from the CDC and others, is that approximately 850,000 persons residing in the United States are chronically infected, although the actual number may be as high as 2.2 million, since a lot of this data is based on passive surveillance reporting to local, state, and then national health officials. We know that hepatitis B is a leading cause of cirrhosis and hepatocellular carcinoma worldwide, so we really think that this is an important public health burden to adequately address in our patient populations. And in addition to this, up to 50% of HCC, here again, hepatocellular carcinoma, which is really the leading cause of primary liver cancer, is associated with hepatitis B infection, even in the absence of a lot of scarring, or what we call cirrhosis. Hepatitis B is only second to tobacco in causing the most cancer-related deaths, and it's 50 to 100 times more infectious than HIV. So again, as we said, globally, close to 260 million. It's really important for us to kind of get our heads around who our at-risk populations are, both globally and here in the United States. So we estimate that, again, 3.5% of the world's population have chronic Hep B infection, and that 68% of these 257 million persons globally actually are from Africa and are the Western Pacific region. And 2.7 million persons who are infected with chronic Hep B are also co-infected with HIV, and most infected persons were born before our now, a widely available, highly effective vaccine that we've, implemented here in the United States starting in 1991, which really led to a steady decline in the number of new cases of hepatitis B. So one of the questions you were asked at the beginning of this talk was who falls into kind of a high risk, high prevalent hepatitis B region. So the highest prevalence, and high here is denoted as greater than or equal to 8%, is shown in green. So we often think of East Asia and Southeast Asian regions of the world, as well as Sub-Saharan Africa. Intermediate regions are what you see in the darker shade of blue here. That's typically defined or denoted as a 2 to 7% Hep B surface antigen prevalence. And again, we'll be talking about the serological markers, but this is the marker for chronic infection. So that helps us determine the prevalence. And then low regions of prevalence, which actually the United States and most of North America falls into, but I'm going to show you on the next slide how that's really subject to interpretation here. So we know that immigration has a high impact on hepatitis B prevalence that we might see in the various parts of the world. So this is based on immigration numbers by continent over the last decade or so, a little under the last decade, 2010 to 2017. And you can see that our highest risk populations here, including what we see in the United States, are in large part based on our foreign-born populations and having a really good understanding of what the country of birth is for people who we might be seeing in our practices on a day-to-day basis. So Hep B infection is, as I mentioned, largely shouldered in our foreign-born population here in the United States. Migration actually accounts for 95% of new cases in the United States that are reported to our public health departments. 90% of foreign-born persons with Hep B immigrated from regions of intermediate to or high, which again, the 2 to 7% and greater than or equal to 8% really refers to those with chronic infection as defined as surface antigen to hepatitis B prevalence. So the top countries of origin of foreign-born persons with hepatitis B infection in the United States include China, Vietnam, Philippines, the Dominican Republic, and Mexico. And if you look at Hep B prevalence rates among foreign-born persons by region, based on data as recent as 2012, Africa accounts for 10.3%, Asia 7.3%, Oceania close to 5%, the Caribbean population's 4.5%, and all others in terms of foreign-born contribution, 3.45%. Now, if you look at kind of what's happened over time with respect to trends in immigration, what you'll see is that the number of persons immigrating from various countries over time, so this starts with looking at data as far back as 1960 all the way up through 2017. And you see that we've kind of had a steady rise in persons immigrating from China, a more dramatic kind of steeper curve in terms of the number of persons immigrating from India, the two most populous nations, obviously globally. And this is then followed by higher rates of immigration of persons from the Philippines, as well as other countries that you see here. And these are countries, as we just mentioned on the slides before, that have high rates. Some of them have high rates or intermediate rates of Hep B prevalence. So the World Health Organization, as well as the CDC and others, have been talking about how can we establish goals globally and here in the United States for eliminating hepatitis B. Hepatitis B is preventable through a highly effective vaccine. We have treatments to try to control and suppress the virus, with new treatments kind of on the way that we might have the promise of developing curative treatments in our lifetime. And so these goals are really meant to be tried to achieved by 2030. And elimination here is defined as the 90% reduction in new hepatitis B infections and 65% of reductions in hepatitis B related deaths. And what you see here is, well, as of 2015, we've made a lot of progress with respect to improving potential routes of transmission through blood safety improvement measures and expanding our hepatitis B vaccine coverage. Really, as of 2015, we still lag pretty dramatically in terms of kind of this critical first point of diagnosis. So screening, therefore, is very, very important. So it's important for us to understand who's at risk and who we should be offering testing to, as well as treatment. And so we have a long way to go in order to really achieve these goals by 2030, as you can see. So moving a little bit from epidemiology and elimination goals, I wanted to talk a little bit about modes of transmission. So we know that worldwide, in endemic countries where they have the very high rates and or even intermediate rates of Hep B infection prevalence, that mother-to-baby transmission is still globally accounting for more than 50% of cases of transmission of hepatitis B worldwide. And this is most common in the East Asian, Southeast Asian countries that we talked about. This is followed by horizontal within household during early childhood. This is probably to a larger extent seen in combination with mother-to-child transmission in regions of the world such as sub-Saharan Africa. And then this is followed then by healthcare, unfortunately. So iatrogenic causes of hepatitis B transmission in parts of the world where reuse of non-sterilized needles and syringes in resource-poor settings and contaminated blood products is still happening today. And then another risk factor that's a bit less well studied, but we believe to be still contributing as a mode of transmission, has to do with this concept of traditional medicine practices that are specific to a region or local area. In non-endemic countries, such as the United States, we believe still the leading route of transmission is through unprotected sexual intercourse. So this is a sexually transmitted disease. We think that this accounts for, 4% of cases of Hep B infection here in the United States. And what we've seen over the last few years is a rise with, in relation to the rise in the opioid epidemic, with really unintended consequences, which have included a number of infectious disease transmission, including hepatitis B, along with hepatitis C and HIV, unfortunately. So there are a lot of myths about how hepatitis B is transmitted, and so it's really important to try to dispel these myths, not only from a healthcare provider standpoint, but really to translate this knowledge about what these myths are to our patients, because this actually leads to a lot of stigma, which is still a really important barrier to identifying and caring for patients with hepatitis B infection. So we know that hepatitis B is not transmitted through casual contacts such as hugging, shaking somebody's hand, even kissing them, sneezing or coughing. It's also not transmitted through breastfeeding. So breastfeeding is safe in infected mothers. And it's not transmitted through sharing utensils or drinking glasses. These are very common, unfortunate, stigmatizing cultural myths. And then it's not an airborne, foodborne, or waterborne, illness, so it can't be transmitted through these routes. So what we've seen over time is that we certainly have, at the present time, availability of antiviral treatments that really work to try to suppress hepatitis B virus replication. What we're seeing now, kind of in this new wave of treatments that are being developed, is developing treatments that really try to target hepatitis B in various parts of its life cycle. So obviously, hepatitis B enters the cell. One of the unique parts about hepatitis B, and unlike hepatitis C, is that this infection in the chronic setting, the virus actually integrates into the host DNA, into what we call this covalently closed, DNA, CCC DNA. And so currently there aren't curative therapies for hepatitis B, but what you can see on the slide is that the new therapies are really targeting the virus at different points of, preventing entry into host cell, working on different parts of the replication cycle to really try to eliminate Hep B and cure patients of hepatitis B, which, I think we might be lucky to potentially see in our lifetime. So now the outcome of hepatitis B virus infection is really largely influenced by the age at which the virus is transmitted. So as I mentioned, worldwide, more than 50% of the burden of infection is transmitted mother to child at or around the time of birth. And in this scenario, more than 90% of infection goes on to stay within the newborn baby and go on to be present as chronic infection. And this really changes over time. So as the age of a person increases, the risk of having chronic infection drops over time. So you see this going down. And so again, if this is sexually transmitted as an adult, we really believe that 80 to 85% of people will clear this infection spontaneously through their immune host system. But unfortunately, still 10 to 15% of people will go on to develop chronic infection when this is acquired as an adult. Now, the natural history of hepatitis B infection really is influenced by the number of years, and which for a large part of the population translates to the age at which it's acquired. So again, in this early phase of acquisition, in the first couple of decades, or if you acquire this in childhood, you're in what we used to call this immune tolerant phase. So I'm going to in the subsequent module, talk about some of the older terminology and what new terminology we have transitioned to. So this older terminology was this immune tolerant phase. This was largely seen you know, in E antigen positive patients. And what we know is that we know that less than 30% of liver cancer associated hepatitis B, again, which is one of the consequences of having this for decades in terms of those that are chronically infected, occurs really in the absence of a lot of scarring or advanced fibrosis. So this is a virus that, you know, we believe directly, independently of fibrosis, really increases your risk of developing liver cancer over time. So who should we be testing? And, you know, really the focus of this module today is going to come down to this. So we know that persons born in high and intermediate endemic areas, so it's really important for us to be ascertaining the country of birth when we are interacting with patients in our practice. So really any place that has, any country that has greater than or equal to 2% prevalence of infection, so anybody in the green or dark blue on the earlier slide that I showed. And then US-born children of immigrants from high endemic areas. So it's really important to not only know where somebody's born when we're seeing them in our practice, but also to know if their parents were immigrants, and if so, where were they born? And so any children born of immigrants from high endemic areas, which we talk about as being greater than or equal to 8% surface antigen prevalence, and if not vaccinated in the United States as infants, is recommended to be tested for hepatitis B. Household and sexual contacts of hepatitis B carriers. So once we identify somebody through screening as having hep B infection, it's important to also find out who else lives in the household and whether or not they've been offered hep B screening, as well as any sexual contacts of somebody with known hep B infection. And then this also includes persons who have injected drugs, persons who have a history of multiple sexual partners or a history of sexually transmitted infections, men who have sex with men, inmates of correctional facilities, individuals with chronically elevated ALT and AST levels, those liver enzyme tests. As part of your workup, hepatitis B should be investigated. Individuals infected with HIV or hepatitis C should also be screened for hepatitis B. Any patient undergoing dialysis, which we'll talk a little bit about in the very last module in this series. Patients who are immunosuppressed, which we will also be discussing. All pregnant women should be offered hepatitis B screening, and infants born to hep B carrier mothers should all be tested as well. So in the United States, the United States Preventative Services Task Force puts forth screening recommendations and also grades these recommendations. They have, you know, endorsed screening for persons born in regions where the hepatitis B prevalence of infection is greater than or equal to 2%. So really any place here that's in blue and or red, and then US-born persons not vaccinated as infants whose parents were born in regions with high prevalence of hep B infection, as denoted as being in red here, okay? So those are people who we definitely should be testing and screening for hepatitis B infection, in addition to the other ones listed on the slide previously. Potential consequences of chronic hepatitis B infection. So remember, this is largely a silent infection, unfortunately, for most persons, that can lead to cirrhosis or end-stage liver disease over time. And it is independent of any scarring, which we know scarring is a risk factor for liver cancer. The virus itself is independently associated with liver cancer. And hepatitis B actually accounts for, you know, the vast majority of liver cancer cases worldwide. 60 to 80% is what we estimate. And it is a carcinogen, only second to smoking tobacco in causing cancer deaths worldwide. So this just kind of shows you what happens over time. So acute infection, again, depending on the age at which it's acquired, it can put you at risk for developing chronic infection. 5 to 10% of people who are chronically infected will go on to develop liver cancer, unfortunately. And again, a lot of acute and chronic infection is silent for most people. In up to 65 to 70% of people, acute and chronic infection is silent. 30 to 40% of patients will go on to develop cirrhosis, which can then also increase your risk of development of liver cancer and development of liver failure or signs of liver failure. This is still a leading indication for liver transplant in the United States and abroad, and contributes to unfortunate number of deaths due to viral hepatitis. We know that the hepatitis D DNA virus level, what we call the DNA PCR, is associated with increased risk of cirrhosis. So the highest, your higher your viral level over time, and this is based on data from the REVEAL study that was done in a long-term follow-up study of untreated surface antigen positive individuals in Taiwan. So the higher your virus level, which is shown here, the increased risk of developing cirrhosis over time, as well as this virus level contributing to an increased risk of development of liver cancer over time. As I mentioned, this infection is largely silent for most people, and so the challenge we have is convincing asymptomatic individuals to be tested, and so therefore it's really important for us to understand who our at-risk populations are and then offering it to any of these at-risk populations. We certainly see even that people in the silent phase in early stages of liver cancer and liver cirrhosis. So it's really important that we do a proactive job of testing patients who are at risk. Liver panel tests may not be abnormal, so a lot of times they can be normal. And 2 out of 3 chronically infected persons here in the United States, we believe, are still unaware of their infection. So screening is really important. In order to offer effective screening in our practices, it's important to understand culture-specific barriers. So we know that there are barriers on the patient, provider, and even on the health system side of things. On the patient side, we clearly know from the Institute of Medicine report that was published back in 2010, there's a clear lack of understanding in our lay communities about who's at risk, how this is transmitted, and that this is a silent condition for most people. There are a lot of cultural beliefs and shame associated with infection and even with risk factors that might put people at risk for infection. So it's important to try to address these. Privacy is still a really big concern, particularly because this is an infection that's shouldered, the burden of which is shouldered in our foreign-born populations. So who this information and the test results get disclosed to, there's still a lot of myths about this. I encounter a lot of patients who are afraid that they will get deported for disclosure of their hepatitis B results. So it's really important to understand that there are a lot of privacy concerns, that this might influence insurance, this might insurability status in terms of life or health insurance, as well as privacy around whether or not this could impact going to health professional schools and training and becoming health professionals. We still see that discrimination and privacy issues existing. So it's important to address cultural barriers to screening, really impress upon our patient populations who are at risk the value of testing and that we have really effective treatments. And even for people who test negative, there could be opportunities for prevention through a highly effective vaccine, and really impressing upon people that this is an asymptomatic condition for 2/3 of our patient population. So unless we test, even if you don't have any symptoms, we won't know whether or not you have it. And then understanding that there could be financial and language barriers to offering the testing. So particularly patients who are uninsured, trying to try to maximize utilization of potential resources that might be available to still get them tested. So some of the solutions for patient barriers and not having insurance, as I just mentioned, a lot of local community health centers and sometimes public health departments now are providing hepatitis B screening and vaccination. So contacting your local agencies and health centers to see what resources are available is an important part of addressing this barrier. And then really provide appropriate patient education materials. So these can be offered in waiting rooms, exam rooms. A number of resources are available online if you check out this link here at the CDC. And then really providing a lot of education and engagement to our patients. So providing a context for why it's important, eliciting a family history to identify risk factors, discussion of the risk of co-infection with HIV and hepatitis C, and even something called Delta virus, obtaining alcohol use and sexual history, and counseling for cessation and abstinence in those who test positive, and explaining what it means to have the infection. So if you're going to do the screening, we need to be equipped to really counsel patients on what it means to have infection and how we can effectively manage it, highlight ways in which transmission can be prevented through vaccines, and emphasize that hepatitis B can be really effectively managed through very effective antiviral treatments. Now, there are a lot of clinician barriers to offering screening as well. So we are often flooded with a number of things to try to keep track of, to try to accomplish on a single visit, particularly if it's the first visit, a primary care visit. Hep B serologies can be very difficult to consume and feel like you have confidence around what tests are for screening. Once those test results come back, how do I interpret it? How do I relay those serological results to my patients? And then if the test results in a positive result, what additional things can I be thinking about doing, either to further manage the patient myself or refer them to a specialist? And then really the guidelines over time have been, to be honest, very conflicting and confusing to consume from a provider standpoint. So we're going to try to make this an easier thing for our providers to consume through the course of these webinars. And really a lack of, leveraging electronic health records and other system-based practices to know who we should be testing more effectively. And then solutions for clinician barriers. So making Hep B risk assessment and appropriate screening really routine in your practices. I was actually at a national meeting yesterday in Washington, D.C. that Hepatitis B United and Hep B Foundation were hosting, and really heard about some really interesting models leveraging electronic health record prompts. There's a group in New Jersey that's done a really, really phenomenal job of actually offering screening for any foreign-born persons who are at risk coming through the emergency department. Understanding Hep B screening guidelines to know who you should be offering testing to, identify effective ways to engage patients around screening, learn how to effectively screen for Hep B and interpret those serologies, and identify opportunities for prevention through this highly effective vaccine, and knowing when and how to refer patients to hepatitis B specialty care if needed. And system solutions, really working within your practice group, your practice setting, your hospital administration, your clinic administration, to see how you can effectively, standardize screening practices and make sure that there's this is offered to all patients, independent of which provider they might see. And then screening those who have been vaccinated is still an important issue to be reminded of. Some patients may have been infected with hepatitis B before they actually received a vaccine. So a lot of patients self-report having been tested or vaccinated for hepatitis B, but it turns out they actually have chronic infection and were inappropriately vaccinated, or the self-report may not always be accurate. So it's really important, if they're from a high risk or an at-risk population community that we defined on one of the earlier slides, to still offer testing if they're telling you by self-report they've been vaccinated before, because there are a lot of people who are inappropriately vaccinated and are actually chronically infected. And so really we need to offer the testing to know, and the testing can help determine who actually has been vaccinated, who hasn't been effectively vaccinated, and who might still be chronically infected. All right, so with that, I'm going to have Cade go ahead and launch our first part of our video, and this is going to be our case discussion for today. So after this, I'm going to ask the participants to really chime in as part of a discussion.
Great, so thank you for all of that, Ponni. I'm just gonna open up the video here. And here we go, everybody.
Yu Wen Lee is a 28-year-old woman who presents for a family planning visit. Yu Wen was born in the United States to parents who immigrated to the U.S. from Taiwan 30 years ago. She has no significant medical history. Hello, Miss Lee. I understand you're interested in becoming pregnant.
Yes, my husband and I have been talking about it for a while, and we think it's time. My parents will be so excited.
Have you told them yet?
Not yet, no. I wanted to talk to you first. I wanted to know what to expect before we started telling people.
Okay, well, this is a good place to start. There are a few tests we can consider, and we'll talk about your lifestyle habits and your health history.
Okay.
I see in your records that you received most of the recommended vaccines, and you were born in the U.S.?
Yes, my parents are from Taiwan, but they came to the US before I was born.
Any family history of illness?
I don't think so. My dad takes medication for cholesterol, but he and mom are fine. And I'm my only child. I did have an aunt who died a couple years ago in Taiwan. They said it was liver cancer, but I didn't know her very well.
Okay, let me ask, have you ever heard of hepatitis B?
I've heard of hepatitis.
Well, hepatitis B is a virus. It can cause liver disease and liver cancer if it's not treated. The reason I ask is that hepatitis B is common in certain regions of the world. Taiwan is one of those areas.
Do you think that's what my aunt had?
Well, it's possible, but I couldn't say for sure. But we should definitely screen you for hepatitis B since your parents were born in Taiwan. National guidelines recommend a one-time screening of people born in countries with a high amount of hepatitis B, and that extends to children born in the U.S. to parents from those countries.
Oh, really? How's it transmitted? Can it harm my baby?
It can be transmitted through body fluids like blood or semen. For example, it can be transmitted through sexual contacts or injection drug use. And it can also be transmitted from mother to child during pregnancy or birth.
No, my mom and dad met in high school. There's no way they got a sexually transmitted disease. And I married my first serious boyfriend. No one in my family has ever used drugs. This can't apply to us.
Okay, let's just go ahead with the rest of the exam for now. Okay.
All right, so a bit of a dramatic conversation, but it's really meant for us to kind of open it up to discussion now. I would love to hear from the participants here, to think about what things from the provider standpoint might you have done differently for UN in that conversation. People want to take themselves off mute and chime in? Is there additional information that you would want to discuss with the patient or questions you might want to ask UN as a provider?
So the additional question would have been whether she's been vaccinated against hepatitis B infection. That would be the question that I would ask first before offering the hepatitis B screening.
And let's say, so that's really helpful, Sadesh. So if she says, yes, I've been vaccinated, what would that lead you to do next?
Since I don't know what the hepatitis B status of her parents is, because she's already 30 years old and she was vaccinated as a kid, she's planning to become pregnant. I would offer to check her hepatitis B surface antibody titers to see if she's adequately covered. That's what I would do.
Okay, so essentially offer some screening to try to sort out, is she infected? Is she protected, to really understand her status, because she's coming to you talking about family planning. So there's several reasons. She also mentioned family history that alluded to some type of liver disease. We know that, in regions of the world, including Asia, this mother-to-child transmission, and so therefore this family history is really kind of an important a part of what we should be asking our patients.
Absolutely.
That's really helpful. Others, anybody else have any other thoughts in terms of what other questions you might want to ask UN?
This is Chen Chi. Can you hear me?
Yes.
So I thought that if the provider can emphasize that the disease is really asymptomatic, so there's no obvious symptoms, and to emphasize that the virus often pass from mother to child, and especially with people who are from Asia, so I think that if the provider emphasize that, and then to suggest that she get tested, because there's really no symptom, and then this is a way as just to make sure that she will be protected, make sure that she's not infected.
I think those are really great points you're highlighting. So you kind of, I think, are picking up on this a bit of a stigma, if you will, with the association of the mode of transmission of this infection through unprotected sexual intercourse and injection drug use. So really highlighting upfront that mother-to-child transmission, maybe that should be the one of the first things we mention to our patient populations to try to really engage patients better and try to work around some of that stigma and diffuse it. And then there was another part, sorry, I'm blanking on one other part of what you just said. So the family history part is really important to as a reason for why we should be offering the testing as well. So really great points in terms of how we can more effectively have this conversation with our patients. Anybody else?
Hi, this is Natalie. You can hear me?
Yes.
Okay. I think the provider was trying to be very matter of fact, but was overwhelming the patient with too much information, too much education about the transmission, and put her on the defensive, causing this stigma, as you said. And if she had maybe focused just on where she came from and the fact that this is common and this is a routine screening for individuals from certain areas, and then waited to do some more of the education in pieces as they went along, maybe it would have worked better that way. I just felt like she really put her on the defensive.
Yeah, so it really sounded like the patient was really expressing kind of a sense of being overwhelmed. So I agree with you. So really trying to tailor this discussion more effectively to engage the patient. So maybe giving it to them in kind of parts and then let them respond. And then, I think one point that Chi, you also mentioned was really stressing the asymptomatic nature of this infection. So really highlighting that unless we test, we really don't have a good way to know your status unless we have actual test results to look at that have already been done elsewhere. And so the benefits of testing is can be either to reassure them that they don't have infection and really know their status to know how we can move forward. So that's really helpful, Natalie. Thank you. Anybody else? Okay, with that, I want to be mindful of time, and I'm sorry we're running just a couple minutes over. I want to show the kind of optimized version of that video. So Kate, if you want to play that.
Absolutely. So
Great.
Here we go with version 2.
Let's just go ahead with the rest of the exam for now.
Do you think that's what my aunt had?
All I would say is that your aunt's history raises my level of concern. I recommend testing you for hepatitis B because your parents are from Taiwan and also because you're considering becoming pregnant. The Centers for Disease Control and Prevention recommend a one-time screening of people born in countries with a high amount of hepatitis B, like Taiwan, and that extends to children born in the U.S. to parents from those countries, like yourself. It's especially important for you because one of the main ways hepatitis B is transmitted is from mother to child during pregnancy or birth.
You mean I could have gotten it from my mom without knowing it, and I could pass it on to my baby?
That's correct. Outside the U.S., mother-to-child transmission is the main route of transmission for hepatitis B.
But none of us are sick. I mean, my aunt died. Shouldn't we be sick?
People who have hepatitis B can seem fine for many years before they start to show symptoms. It's often silent. We want to treat anyone who's infected before they get sick, and also to prevent them from giving it to someone else.
I get it. I guess that's okay.
If the test comes back positive, which is unlikely, we can talk about how you can discuss this with your parents.
Oh, sounds a little scary.
Well, getting tested is the right thing to do, and it's a treatable disease. For now, we want to ensure that you have a safe pregnancy and a healthy baby.
All right, thank you.
So I think, discussions with patients are never perfect. I'll start by saying that. And even in our optimized version, I think we could have a discussion about even some additional things that we may want to tweak in terms of how we're engaging that patient further. I think given the time, I'm just going to go back to my slides really quickly. And then we can take some questions to wrap up. So let's see there. Okay, so we're just ending on a question slide here. So I just wanted to kind of open it up now. In this first module, I hope you really got a sense of kind of the epidemiology globally here in the United States, and then about who's at risk, who we should be thinking about testing, what information we need to be able to know who's at risk, and then really how effective strategies we should try to incorporate in terms of engaging our patients around screening. So with that, I'm just going to open it up to any questions and see if there and any feedback really on this first session. You could feel free to unmute yourself or use the chat function.
All right. Well, Ponni, I figure maybe now, just for a minute or so, if nobody's got any questions or something to say at the moment, I'm just going to launch a couple of those sort of final polls to wrap up some of the education that Dr. Perumalswami went through with you. So similar to what we did at the beginning of the presentation, you're now going to see a few polling questions pop up on your Zoom platform. There's only 3 this time, and they're going to look very familiar. So the first question again is, how confident are you in identifying patients who are at high risk of hepatitis B? Do you feel not confident, slightly confident, moderately confident, or highly confident? Keep in mind your answer may have changed since what you answered at the beginning of the presentation. It may have not. Either is okay. We just want you to answer as honestly as possible. So I'll leave that up for another 5 seconds or so. All right, great. We've got 2 more questions for you. The next one, which you should also recognize, is how confident are you in overcoming patient barriers to screening? Do you feel not confident, slightly, moderately, or highly confident? And again, I'll leave that up for a few more seconds. Great, thank you all. And we have one final question that we'd like to gauge from you today, which is, again, you're going to select the amount that you agree with the following statement, which is, I am able to identify patients who are at high risk of hepatitis B. Do you feel that you are never, rarely, sometimes, often, or always able to identify such patients? All right, I'll leave that up for a few more seconds now. And perfect. All right, that is all the polling I've got for today. So Ponni, I'll pass it back to you. Thank you for that.
Okay, great. So hopefully we're moving the needle a little bit in terms of confidence around a screening. These slides will be available after today's talk. You can refer to them, print out, parts of it if you want. If you have specific questions, I'd love to open it up now, but if you have it, think of something kind of later, you can email me or call me and we can discuss it. Are there any other comments or questions that folks wanted to discuss today?
So, I had a question about the initial discussion that we had. Would you have offered hepatitis B surface antibody test, or it's just out of line to offer that test?
So typically when I do screening, I do surface antigen and surface antibody.
Sure.
The CDC and others also encourage to do the core antibody testing. Now we're going to talk about serologies in the next module in a little bit more detail. In certain settings, like for example with immunosuppression, before giving immunosuppression therapy and other things that we'll talk about in the series. So I typically get all 3 off the bat. If you you also kind of, I think getting all three is helpful, because if your surface antibody comes back negative, I kind of still want to know if there's an opportunity for vaccination, which I won't know unless I have the core antibody test.
Sure.
And then I'm still left with, well, is the person chronically infected, and do I need to still do the surface antigen? So I think getting all three off the bat is typically what I find easier.
Sure.
That way I don't have to come back and draw more blood and have further discussions and raise alarm without having the best information to present to a patient.
Right. One of your slides actually mentioned that if somebody is vaccinated, even though their parents are immigrants,
yep.
Would they still need to be tested? Is the question. I initially had some doubts, to say that she does not need any testing because she's been vaccinated.
Yeah, so the only thing I would say is that there have been studies, most of the studies I think have been done on the West Coast, where particularly with the Asian population of patients, where there's been a lot of self-report. So they basically had people fill out a survey, and the survey included self-reported, I've been vaccinated against hepatitis B, hepatitis B virus, and then everybody got screening. And then they looked at the screening results. And what they found was that there was up to 10 to 15% of people who were chronically infected based on their test results from that screening study who actually reported being vaccinated against hepatitis B. So we know that there's a lot of, a lot of times it's hard for patients to remember what they've been vaccinated against. They confuse hepatitis B with other things that they may have been vaccinated against. And so, so I think there's a lot of people who will still self-report that they've been vaccinated, and there's still kind of this hidden burden of people who are chronically infected. So we really need to offer the testing.
Okay.
I think it's a different scenario if you actually have test results to try to interpret, but without that, I don't think you can confidently really. We don't base anything completely on self-report. Usually we want to get the other records if at all possible. Sometimes that's not possible, depending on where the person may have been treated or vaccinated before.
Okay.
Yeah.
But if they've been vaccinated and we have records, we don't have to screen?
You don't have to, because they've already been tested.
Right.
So we don't have to test them again. So, but oftentimes we don't have records, given our fragmented healthcare and that records don't go with the patient. We have to chase them down. So if you can get the records, then then they've already been screened, right?
Right.
But without records, which is kind of the most common scenario I think we all face, or inability to get them, then offering the testing is really important.
Okay, thank you.
Yep. Anybody else have any other thoughts or questions or comments? Okay, I think I have something in the chat coming through. Let's see if there's any. Okay. Yeah, I don't see that there's anything else here. And Chris, it looks like you posted something to the group.
Yes, so actually I'll just make a quick note of that, which is Chris just shared a link in the chat window that everybody should be able to see. That will link you to a post-test and evaluation for the program. We really encourage you to take it. It helps us not only sort of measure how the learning and the education is going, but if there's anything that you think could use improving on, or anything you'd like to see differently, or things that you may have appreciated, really just helps us sort of finesse and fine-tune, not only for future programs, but for the next few modules that you will all be encountering as well. So any feedback is much appreciated. So we really encourage you to click on that link. Relatedly, we will also be sending you a follow-up email tomorrow that will include that link if you don't have time to access the test today. And as Ponni mentioned, you will also be receiving this entire slide deck, so you can review these slides as in-depth as you would like. You'll also see some information about the next module. I'll just tell you now as well, the next module will be taking place same time next week as today, so it will be Thursday, August 1st, beginning at 12 p.m. noon Eastern time. Same time as wherever you may be joining from around the world today. It's just going to be on that schedule for the next few weeks. And furthermore, Rachel, who you met, who's one of our other coordinators, will be sending you an official calendar appointment to the email as well, so that you can just have it officially in your calendar and you won't forget about it this way. And my very final piece of housekeeping is that that email will also include a case presentation form. Dr. Perumalswami made mention of this earlier. It's going to be sort of one of the major points of this boot camp. There we go, perfect. So we'd also like to ask if there's anybody who would like to volunteer now to fill out the case form for next week. Please do. You can just unmute yourself and let us know. If you don't feel comfortable yet, just let us know via email if you would, and we'll be following up with all of you as well. But at this juncture, is there anybody who would like to volunteer to present next week a patient case?
So we'd love something related to serology, interpreting, screening serology.
This is Natalie. I have one that's about interpreting serology that just happened the other day.
Okay.
That's fantastic, Natalie. Yeah, in that case, in the follow-up email you see from us, there'll be a downloadable version of the case presentation form. And if you could just fill that out at your own convenience and send it back to us, and we'll address it next week, that would be fantastic.
Okay.
Great. Well, thank you so much, Natalie. And this will be sort of a great template for all the other learners as well. We'll see sort of how a case presentation will work, and hopefully that will remove a few of the barriers to wanting to present your own cases, but we want you to feel as comfortable as possible. And that all being said, both on Ponni's end and on the learners, is there anything else that you would like to address? Any questions before we end this meeting?
Just want to say thanks to everybody for joining. Look forward to next week.
Absolutely. I can't echo that enough. Thank you all very much for taking time out of your schedules, and thank you to you as well, Dr. Perumalswami, for leading us through Module 1. We very much look forward to discussing serology Part 1 with you all next week, Thursday, August 1st at 12 p.m. Eastern. So until then, have a great week, and keep your eyes peeled for a follow-up email from us tomorrow. All right. Thank you all very much. Have a great day.